Good evening, everyone, and welcome to the webinar, Impact of Shingrix Vaccine Schedule Changes on Pharmacy. Thank you for joining and for taking the time to attend today's webinar. My name is Ruth Ackerman, and I'm the Director of Professional Development at the Ontario Pharmacists Association, and I will be your moderator for this evening. This is my OPA slide, and one of the activities that OPA is proud of is the work we do to develop practice tools and resources like this webinar and a tool we'll be talking about today for pharmacy professionals like you. We want you to know that without the support of our members, OPA would not be able to continuously advance the pharmacy profession. Our members make what we do possible. A special thank you. I always have to say this to all pharmacists, pharmacy technicians, assistants, interns, and students who are working on the front line and have stepped up to protect our communities and Ontarians, and we are very grateful. I also want to thank GlaxoSmithKline for their support of pharmacy. So why are we here today? Well, effective July 26th, the National Association of Pharmacy Regulatory Authorities, or Napra, announced that the non-live recombinant herpes zoster vaccine had been granted Napra Schedule 2 status, and the national drug schedules for non-live recombinant herpes zoster vaccines, such as Shingrix, was updated. This change in Schedule 2 allows more flexibility and increased access to Shingrix for patients who are not eligible for the publicly funded immunization program by not requiring a prescription from the patient's primary care provider prior to the dispensing of a non-live recombinant herpes zoster vaccine. So we're here to talk about how to incorporate this change into your practice and what it means for you and your staff. We also want to introduce you to a resource that we have prepared for pharmacy professionals to help you manage this change. So this resource, hopefully you will see it in the chat. I will try it again if it doesn't work. It's called the Pharmacist Clinical Tool for Initiating Shingrix Discussions. This is just a snip of it. It's much larger than this. The tool is available on our website. And if I don't get it in the chat, you can go to the website, or you will get a follow-up email from us on Thursday, and I will have that link in the email. And so hopefully you'll find that beneficial to you. We're really happy for GSK's support on this. So now let me talk about our speaker. And at the same time, I'm going to stop sharing my screen so that she can start loading up her program. Just before I go on, I just wanted to mention that I'm not sure if you're aware, but NACI just came out with new guidelines, surprise, so which will affect what we're talking about today a little bit. And that's the guideline around the co-administration of vaccines. So this is what they said. I'll just read it right from the Canada.ca site. COVID-19 vaccines may be given at the same time as or any time before or after other vaccines, including live, non-live, adjuvanted, or non-adjuvanted vaccines. So you can read more about that on Canada.ca or Twitter. Just seems to be where people get a lot of information. So I'm really happy to introduce Pavitra Ravi. She's a consultant who's been in the pharmacy industry for over 10 years. Her experience includes working in long-term care, specialty pharmacy, compounding, and retail pharmacy. Furthermore, she has a diverse background in pharmacy management, financing, pharmacy workflow, automation, technology, and insurance. Pav is a true passion for community pharmacy and supports patient-centered care. Motivated by her desire to help support the value, emphasis, and role of pharmacists, she has been a presenter and a collaborator for various platforms. Take it away, Pav.
Perfect. Thank you so much for that introduction, Ruth, and thank you everyone for being here today. I did want to ask before I started, is everyone able to see the actual PowerPoint that I'm playing? Or is it?
I can see it, but you might want to put it in presentation mode.
Oh, it's not showing in presentation mode? Let me see.
Just go down to the bottom. Put it down there.
It shows its presentation on my screen. I don't know if that's
There
what
it
it's.
goes. Oh, now it's showing you your whole. Don't you just love? Well, you can just do it like this. Just push the
Perfect.
slide to the side. We're
No
used to
problem.
this.
I love it when I have multiple monitors and they don't want to work with me, but that's okay. Hopefully everyone can see the screen right now, and my apologies for it not being in presentation mode, but we're not missing much either way. So thanks everyone for joining me here today to talk about the impact of Shingrix vaccine schedule changes on pharmacy, like Ruth had mentioned. And definitely there's been a lot of changes when it comes to vaccine. And as Ruth had just mentioned, there was one that just occurred. So we'll talk about all of that today, and hopefully you'll be able to take something away from today's webinar and presentation that you're able to use in your practice and hopefully help your patients in your day-to-day work. So before I start, I did want to mention a few disclosures and disclaimers, just a bit of information on the fact that I did receive a speaker's brief from OPA for this activity, a little bit about my relationships and commercial interests, as well as activities, and some other components that I've worked with other individuals as well as companies that I've worked with on different programs. So today, what we really hope to achieve is a couple of things. We do want to go over the basic overview of shingles in patients. I won't spend a lot of time on this because I'm sure a lot of you have a deep understanding of this. I wanted to talk about and understand the change in the shingles vaccine to Schedule 2 and what that means to you as pharmacists, as well as your practice of pharmacy. Identify how you can interact with patients who would benefit from the shingles vaccines, as well as go through some of the important information that's required for documentation, coverage considerations, and other components from a workflow perspective that's important to consider when we're recommending as well as documenting shingles vaccines. So to start off with, I was hoping to get a poll from everyone today to get a better understanding of how we feel about shingles vaccines. How many people here have recommended the shingles vaccine to their patients? So this would be question number 1 in your poll. And it's a really straightforward question just to understand how many have had experience with this in their practice and how many haven't. And I know shingles is one of those topics that we don't often see talked about in pharmacy, but it really should be. And with the changes of it to Schedule 2, that definitely puts the pharmacist in a role that's pivotal to ensuring our patients' health outcomes for this condition.
So I don't think the polls are working.
Okay, no problem.
So we will... Oh, wait a minute. Oh, look.
They're working.
Yeah, and they're answering all the questions.
Oh, okay.
So
Perfect.
We'll do a test and then we'll answer it all at the end. So when you need the poll, we'll just get the answer.
Okay,
we only
perfect.
have 3 people who've answered. Oh, now we have 4s.
So we'll go with some of you have and some of you haven't recommended the vaccine. In my experience, anecdotally, most people, especially newer graduates, they're not as familiar and they haven't necessarily figured out the tact to talk to patients about shingles vaccine. And especially right now where everyone's mind's on COVID, it's not necessarily something we talk about, but it's definitely something that we should now consider and try to put into our practice because there's a lot of benefit that can be gained by that. So just a little bit of information that'll help arm you in your discussion with your patients. It's important to note that there have been 130,000 Canadians will develop shingles each year in Canada. That's a lot of individuals considering we have just over 37 million people as our population. And 1 in 3 Canadians will get shingles during their lifetime at some point, and they may get it more than once. And it's important to kind of have these facts on hand because a lot of people don't fully understand shingles and they have a lot of misconceptions and misinformation about it. And it's really making sure that we have some of these facts on hand that'll help us deliver that point so our patients will have a better understanding of why it's important that they get vaccinated against this. So just a little bit of information. What does the change in schedule mean for pharmacy? Of course, as Ruth had mentioned, some of the high-level technical things, no prescriptions required for the shingles vaccine anymore. So it is Schedule 2. You can dispense it without a prescription. It's obviously, you can administer at the pharmacy. That's something that we've had a scope to do. and it increases the access of care to patients. So a lot of the time when it came to the shingles vaccine, you would need a script from a doctor, then if depending on where you practice and before we got the scope for it, sometimes you need to dispense and then they need to go back to the doctor. We've really reduced that sludge in the system where it made it really difficult for patients to gain access and get administration of the vaccine. Now with the latest change, we're able to do everything as a one-stop shop in the sense for a patient. So we're able to now counsel them, identify if they benefit from the shingles vaccine. We're able to identify and dispense the shingles vaccine, and we're able to administer the shingles vaccine as well for the patient. So that efficiency really allows a better outcome for a patient's health. But there's a couple other things to consider as well on what this means for pharmacy. So it also means that it's something new that you may have been doing in your pharmacy with prescriptions, but may have not been. It's as a Schedule 2, recognizing who should be eligible for this service, what patients are your demographic, your target that would benefit the most from the shingles vaccine and how to approach them. It also includes, is your store set up for the shingles vaccine and administration as well as discussion from your workflow perspective, or do you have the right operating procedures or standardized SOPs available if you haven't been doing injections in your store before and now you want to start, as well as are your staff members aware or comfortable with the scope of this? It's not an island that we as pharmacists sit on. It's definitely something that the pharmacy team engages on. By no means, of course, as it being Schedule 2, you still require the pharmacist to be there, counsel when this is being purchased to be administered, but the discussion can be started with anyone on the pharmacy team and then looping the pharmacy in. So making sure that your staff is ready and there and comfortable to support you for this, and as well understanding how and who is covered for this vaccine. So really high level, I won't spend too much time on this because I know we have a lot to go through and a lot of you know this. Shingles is essentially a painful rash that can occur in different parts of the body. Some of the main things to really be aware that patients should really take home with them is the fact that it is burning, it is a shooting pain, it tingles, and it can itch. And it's a blister and a rash that's not something a lot of people have experienced. Many individuals who've had shingles will very clearly say they never want to experience this again. And it's something that not only can be horrendously painful in and of itself, but can actually lead to a number of complications as well. So shingles can lead to one of the more commonly known complications, which is postherpetic neuralgia, often referred to as PHN. And we see that a number of people who end up having shingles suffer from this complication. It is a horrible neuropathic pain that can last for 90 days or longer. So it's definitely not the type of pain that you want to grin and bear it. It's not going to go away anytime soon. And it's important to kind of emphasize this to our patients so they're aware that the condition of shingles is not just it's in and of itself, but it can come with complications that they want to protect themselves against. So about 1 in 10 people who end up with shingles will suffer a form of PHN, but that's not the only complication that comes along with shingles. You can also have ophthalmic complications that studies have shown about 10 to 15% end up experiencing. You could have cerebrovascular as well as cardiovascular complications that approximately 1% of patients end up experiencing. And then finally, you could have neuralgia as well as neurological issues or complications, which approximately less than 1% of patients end up experiencing. And what's really interesting to note is that though in and of themselves, these complications seem fairly low in regards to prevalence, but approximately 10% of patients who end up with shingles will experience at least one of these non-PHN complications. So they do occur and they can be devastating to patients. So it's important to arm ourselves with that information so we can explain why being vaccinated truly protects our patients, not only from shingles, but the complications that can occur from shingles as well. Just to touch on this as well, I'm sure a lot of us know about this information, but how do you get shingles? So shingles, there's a bit of misinformation when it comes to patients about this, but essentially, if any of us, and most of us have had chickenpox when we were young, we now have the varicella zoster virus within us. And essentially, that lays latent until it gets reactivated. And shingles is what occurs when that reactivation happens. There's a number of different things that can lead to this reactivation. So I really want us to take note of the fact that age is one of those components. Age can often weaken the immune system. So with a weakened immune system, you're more susceptible to have that reactivation of the virus. It can also be the medication that we take. A lot of people who may be on certain medication like biologics for inflammatory diseases, they have immunosuppressed systems. So because of that suppression, they're also at a heightened risk of potentially reactivating this virus. And as well, we don't think about this often, but a patient's social or lifestyle circumstances can also impact them due to stress, because we often have accepted stress as a part of our day-to-day lives, but it does have an impact on our body and our immune system. And that can also potentially lead as a trigger to the reactivation of the virus. So it's important to note that there's often this misconception that I've had chickenpox, shingles is not a worry for me. That's not true. It's the fact that you've had chickenpox, that you have this virus internally, and it can be reactivated. And for those individuals who've never had the chickenpox, it kind of poses a double threat, because if you've never had the chickenpox and someone has the shingles and they have blisters that haven't crusted over, you have the potential of contracting chickenpox from that, and then after which you are susceptible to shingles as well. So it's really important that our patients understand this concept as well as we do. So I think we already did the poll for this, but we'll ask the question anyway. If my patient has had shingles already, I don't need to have a conversation about shingles vaccine with them. I'm wondering if many of you agree, disagree, or aren't sure on this concept. So do you feel like if someone's had shingles, it's something that they know, they're aware, I don't need to talk about it with them, they'll know that they need the vaccine, or have decided they don't need the vaccine, and or they feel like it's just not going to happen again for them, so they're going to leave it be? Do we have poll results for this?
I'm sorry, but we do, but I can't launch the poll again.
No problem.
Very sorry about this.
That's okay. We're going to assume that most people probably disagree or are not sure. I'm hoping not a lot of people agreed with this, because it's not true. And the reason being for that is that there is the possibility of reoccurrence of shingles. In a study of about 16,784 patients, nearly 17,000 patients, it was seen that 6.41% actually had a reoccurrence of shingles. So it's not a one and done kind of concept that a lot of people think about because they associate it with chickenpox. There is the possibility, very high possibility, of a reoccurrence of shingles. It's also important to note that if you've had shingles before and perhaps it was in an area or dermatome that was less uncomfortable, it wasn't on your face, you were still able to go to work if needed, that's not necessarily going to be the case if it does reoccur. Only 16.3% of patients were seen to have that reoccurrence happen at the same dermatome that they originally did. Majority of patients have it somewhere different. And of course, we all know that the last place anyone wants to have that occur is on their face, because it's very painful. It's an area we often touch. And if you do have it in that location, you certainly can't go out to work. And while your blisters have not crusted over, you do have that potential to possibly impact or affect anyone who has not had chickenpox before. Some other things to notice is that reoccurrence, you may feel like you've had shingles once and it's been a couple years and you haven't experienced it again. This does not mean it's not going to happen again. Studies have shown anywhere between 2 months to 70 years is a possibility of a reoccurrence. In this specific study by Shikari et al., they saw that the mean number of years was about 14 years, where most people who did have a reoccurrence ended up having a reoccurrence. And final point to note, shingles does impact male and females. However, the potential of a reoccurrence was seen more often in females. So that is something to note as well when having these discussions with any individual who's had shingles before, as to whether they would want to have the shingles vaccine and why it would be beneficial to them. So just kind of reiterating the fact that the people who have conditions that may allow them to be immunocompromised, who may end up on medication that causes them to be immunosuppressed. These are those conditions and individuals who are at higher risk and have triggers that may reactivate the virus and put them at a potential of having shingles. And just going over really quickly, I don't want to spend too much time on this, but if your patient does end up having shingles, the things that are prescribed to them are often antivirals to help with the severity as well as the duration of the condition, as well. Most often, and multitude of therapies are often for the symptoms associated with shingles, primarily pain. You'll see that they'll be looking for OTCs for pain, whether it's painkillers, for the rashes, whether it be a cold compress or oatmeal baths. It's really across the board that you'll be seeing that medications are used for symptom management when it comes to shingles. And what's important to note, and a lot of patients aren't aware of, is that studies have shown that of those individuals who end up having shingles, 83.2% of them will be treated with medication. So it's not something that goes untreated. It does need to be treated. And of those who are treated, they end up on approximately 4 different medications on average to help with shingles as well as the associated symptoms, whether it be pain, whether it be the rash or the itch that's associated with it. And it's also important to note that approximately 1 out of 10 individuals who get shingles will likely have PHN associated with it. And if you do have shingles with the complication of PHN, nearly 100% of them will be on medication. Almost no one's on medication. And with PHN, you're often on an additional 5 medications just to help with the treatment of pain, because pain ends up being that neuropathic pain is excruciating and something anyone who's had shingles with PHN will truly remember. So it's something important to keep armed in our, I guess, repertoire on when we have that discussion with our patients, that shingles isn't something like chickenpox where I don't need to worry about it. It'll run its course and it'll be done. It has complications and you are of an older age, and it is something that will impact your body and your day-to-day life. And it's important to recognize it in and of itself, and its complications come with a lot of treatments you may have to undergo. So with that, we've kind of talked about shingles. We've gone over how it's caused. We've gone over some of the treatments. We've gone over some of the statistics. Let's take a look, I guess, at some of our case studies.
So I'd like to introduce Olga Mueller for you to do your assessment. So she's 62 years old, and she is immunosuppressed, and she has rheumatoid arthritis. She's taking, as far as medications, and forgive me about my pronunciation here, leflunomide, 20 milligrams daily, etanercept or Brenzis, 50 milligram once a week, acetaminophen, 500 milligrams, 2 tabs PRN. She's recently lost her husband about a month ago, and she has never had a shingles vaccine. So how do you work this up?
So she's definitely a patient that some of us may see in our practice. She has a number of different characteristics that you mentioned that we should really take note of. So really the best path forward is to understand who the patient is. And taking a look at some of the information that you mentioned, you did say that she was 62 years old, so she falls within that rationale as to being on label. She's over 50. She is immunosuppressed. She has rheumatoid arthritis, and she's on a number of different medications for that, specifically etanercept, which you mentioned. So etanercept does cause immunosuppression, so it makes her more susceptible to having a reactivation or getting shingles. You also mentioned that her husband recently passed, and this is something we often overlook at pharmacy, but we really should take the time to have the discussion. Stress is a huge component on our body. It impacts our immune system, and it's important that we recognize that that stressor can actually potentially decrease her immune system and lead to a flare or lead to her potentially having shingles. So it's important to note that down as well. We do need to ask if she's had chickenpox before to understand that, does she have the virus in her, or is she also now a candidate that may potentially contract chickenpox from someone else who has shingles, and that's a concern for us as well. And it's really important that we have a discussion with her. We know her age from her patient profile, we know her medication, but a lot of these other components we don't know. So for Olga, my first component would be to just introduce the topic to her. I would have that discussion to say, have you ever thought about the shingles vaccine? Is this something that's ever crossed your mind? And it depends on the patient. Sometimes they'll be really receptive. They'll say it's crossed my mind. Maybe they know someone who's had shingles before. It may have been her late husband. It may have been someone else that they know. So they already have that notion of knowing how complicated it can be or how painful it can be. And so it's easier to steer that conversation now to say that, is this something you think about? I think it might really benefit you. You know, you are 62 years old and you're on some medications that kind of weaken your immune system and puts you at risk of potentially having shingles. And then asking those questions of if she's had chickenpox before and making sure she doesn't have any known allergies, just rechecking those of what we have on our patient profile. And then essentially everything that we've gathered really points to her being an ideal candidate for the shingles vaccine. Her age, her medications, her conditions, her social and lifestyle states, as well as the fact that she's had chickenpox before as well, something to note. She'd definitely be someone that we'd want to have this purchased and administered in the pharmacy, but we really need to make sure we document this. It's not just the fact that we've had this verbal conversation with her, and everyone's system is a little bit different. But I would strongly recommend either you attach a documentation like this, whether it be that it's scanned in, attached to the prescription, or whether it be attached as a patient note, where we see the prescription number is co-referenced, whichever system you're using, somehow noting down this information, the date and time on which you had this conversation with her, as well as noting down the guidelines, the NACI guidelines that you referenced that truly highlight that she's an ideal candidate, are required to make sure that we've encompassed all our facts. We know that patient really well, and we've actually done our due diligence to have that conversation with her and highlight with her why she needs that shingles vaccine. And finally, as with any service or vaccine that we do in the pharmacy, we want to make sure we have consent. We want to make sure that we've gotten consent from Olga, that she agrees, she understands, and this is something that's a service that we're going to provide to her. So these are some of the components that we really want to consider and document in our pharmacy in some part of our workflow, depending on the system that you use, to make sure that we have the documentation, not only for ourselves, but for if you are a relief pharmacist or you have other staff pharmacists or it's rotational, that the next pharmacist that's looking for Olga when she comes in for her second vaccine, for her second dose, has that information and make sure that there was rationale as to why the first one was given and they can reference back so they feel comfortable about that as well. So it's really a part of that communication between our pharmacy team and making sure we've documented that every action that we take within our scope is in the best interest of our patients as well. So finally, it's important that we have this, but we also want to make sure that it's sent out to her family physician or her primary prescriber as well. So as with anything we do, it's a little antiquated at times, depending on the system you have. You may need to fax it, or you may have EMR systems that you're able to send information digitally, but somehow in some form, we do need to document as well as send that out to our other healthcare providers. So I did want to touch on a couple of things in this patient. So Olga seemed like an excellent patient. I mentioned a shingles vaccine to her. She was really receptive. She wanted to do it. She gave me a bit of information. I let her know the complications she saw perhaps in another family member, someone she knew that had shingles. And she was open to having that shingles vaccine, purchase it and administer it because she recognized she wanted to protect herself from experiencing that. But not all our patients are going to be like that. And in my personal experience, sometimes those patients are few and far apart, and we'll come across a lot of patients who have myths or misinformation, and they really have a rebuttal to anything we say or have a lot of false pretenses as to why they feel that they don't need this vaccine or this medication that we're recommending. So a couple of the things that I've seen patients decline the shingles vaccine for is they've told me shingles is not serious, it's just a rash. And as we all know, that's a pretty easy answer to give a little bit more information to, as it obviously has complications associated with it. It's very different than just a rash. The pain associated with it is highly unbearable, as well as the fact that it can lead to PHN, which can last for quite a while. This was probably the most interesting one I heard. Shingles won't happen to me. I'm very careful and I'm hygienic. So this was a recent one, especially with COVID. A lot of patients feel the denotion of a virus or contracting a virus is if I'm 6 feet apart from someone, I'm wearing a mask, I'm washing my hands, I'm sanitizing regularly, I don't go out too much, I'm not going to get a virus. And it's helping demystify the fact that they think all viruses are the same. They think they're like the cold and they have to catch them. And that's not true with shingles. Shingles is a reactivation of a virus that's already inside of you. So it's helping them understand that, have you had chicken pox before? And most of us have, or are unsure and think we have. Then you have the potential of this virus already being inside of you. And it's not a matter of catching it, but it's a matter of your body becoming weak or your immune system becoming weak, allowing it to reactivate, and it comes out as shingles. So helping them understand that goes a long way. Another one that kind of relates back to the chickenpox component is shingles just goes away on its own. It does not. Shingles can lead to a number of complications that can last for quite a while. And in some cases, it can lead to long-term disability as well. So helping them understand it's not something like a common cold that we can just kind of hope it runs its course and leaves. It can leave lingering effects. Shingles is pretty much the same as chickenpox. We all know that's not true. So helping them understand that and the complications associated with shingles. And finally, the one that I've heard is shingles is not contagious, so I don't need to worry about it. And again, it kind of goes back to that fact where people think they have to catch something to be able to have that condition. And shingles is different. It's different than COVID. It's different than the common cold. It's different than what most commonly people think of when they think of viruses like the flu virus. You have this virus, you have the Varicella zoster virus in you already. It's helping your patients recognize it's that your body's changing as you age. It's that as you take certain medication, it impacts your immune system. And these triggers or these factors can potentially lead to that virus that's latent inside of you reactivating. And that's what we want to protect you against. And that's why the vaccine is so helpful, and that it will basically help alleviate the potential of having shingles, even though in their mind they feel like it's not a concern for them. So I guess this is another different patient that I get to talk about.
Yes. So I want to introduce you to Kyle Schwartz. Now, he's 52 years old. He doesn't have any medical conditions. He's a young, well, he feels young, active, maintains a healthy lifestyle. He's a runner. Wow. He's you rarely ever see him in a store unless he's buying over-the-counter products like vitamins. He comes in for his flu shots, so he's not against vaccines. He is eligible for the shingles vaccine, obviously, but he feels he's too young. I'm active, I run, I take care of myself. It's not concerned. It's something that old people get. Yeah, I had chicken pox, but that was when I was 6. So convinced me.
Fair. Kyle sounds like he might be in better shape than me at the moment. But there's a lot that you mentioned about Kyle that kind of makes him one of those individuals that falls in that category where they have heard of shingles, perhaps they don't fully understand the complications associated with it. They feel like they've done their part. They exercise daily, they eat right, they make sure they maintain their health. So to them, they feel like they don't see any signs in their body where they might be susceptible to something. So why is it something that I should worry about? And it kind of goes back to that main component that we talk about when we talk about talking to patients. It's that ask component where you're sometimes in a difficult spot. You're not trying to force something on a patient, but you're kind of trying to probe and ask those questions where they come to a self-realization where perhaps they started off with the door shut. Now it's creaking open a little. And that's really all you're looking for with someone like Kyle, is you really want them to start thinking about the shingles vaccine and about shingles, because they probably have never thought about it. They feel like they're healthy. They don't have any comorbidities. They probably still feel like they're a teenager and they're invincible because they're doing so well for themselves. And it's recognizing that that's not necessarily the case with shingles. So one of the components is definitely when talking to Kyle, asking if they've had the chickenpox before. So Kyle's had chickenpox when he's 6, and perhaps he doesn't fully understand. It's starting the conversation. Have you ever thought about getting your shingles vaccine? And probably they'll come back and say, no, I don't need it. I'm healthy. I run. Can you run as long as I can? But that's not necessarily just the component. You may be healthy today, but you don't know what's going to happen tomorrow. And it's helping highlight that to Kyle by kind of steering that conversation to, do you know how shingles works exactly? I just wanted to let you know that you mentioned you had chickenpox when you were 6, and it's something that a lot of us have. And the fact that we've had chickenpox means that we have this Varicella zoster virus in us. And that's the exact same virus that causes shingles. So it's not something you need to catch. It's not something you need to contract. It's not something that's a condition driven. It's something that you already have inside of you. So it's important we at least try and think about it and understand it a little bit more, because as we age, obviously our body changes. And I'm really glad that you're running and you're physically fit and you have a lot going for you, but we all don't know what might happen tomorrow. And it's important we protect ourselves today against what might happen tomorrow. So having that discussion with him, again, recognizing that perhaps he feels a certain way today, but arming him with the knowledge. So we've steered the conversation towards, will you consider the shingles vaccine? And then giving him a bit of knowledge that shingles happens to 1 in 3 people in Canada will contract it in their lifetime. It's something that you already have the virus inside of you. It's something as your body changes naturally as you age, regardless of if you have a comorbidity or you have a certain disease or condition or not, it puts you at risk of potentially having this virus reactivated. And it's not just the type of medication or the condition you have. Shingles has a trigger or can be reactivated from any sort of component or factor that impacts your immune system. And one that we all take for granted is stress. Perhaps Kyle's really healthy, but he has potential stress from a certain employer or a client, or emotional stress with certain relationships, whether it be a spouse or children. Recognizing that it's more than the fact that they think they're healthy today, you don't know what will happen tomorrow. And having that conversation with Kyle to help him at least think about shingles. And if you happen to have any resources available, if he's open to taking them away, it's definitely that first approach that's important. Kyle is one of those individuals that could say yes, he could say no, and a no isn't necessarily a bad thing. If today, Kyle, when you have that discussion with him and he says, no, I don't want the vaccine, I don't feel like I benefit from it, that's okay, because you've talked about the topic and it's something that's on Kyle's mind now, whether he admits it or not. And you never know, we're all creatures of curiosity. He might go back and ask a few friends that he knows, have they ever had shingles, or do they know someone who's had shingles? My pharmacist talked to me about it, but I said no. And perhaps you'll hear from another person what that experience was like. That'll help him reconsider if it's something that he should really think about and that the shingles vaccine might benefit him. And it's really important that Kyle has some information about the complications associated with shingles. I think more than anything, people think shingles in and of itself is a rash or a painful condition that they can grin and bear, but that's not necessarily true. The fact that so many people end up with PHN and with other complications is really something to highlight to Kyle, as well as letting him know that if by chance you're healthy today, if you do end up with shingles and it causes long-term pain, that can impact a lot of the things in your life that you enjoy, like running or certain other activities that he does. So it's helping them put the pieces together to see what it might do to them in the future and helping them realize what these complications are, rather than just a disease or a condition they think they may never get. So I know we don't have the poll, but that's okay, because we had a long conversation with Kyle. And the question here would have been, is documentation for Kyle needed? And the answers are no, yes, or optional. And really, this is one of those cases where technically, if Kyle has said, no, I don't want the vaccine, I don't want to talk about it, you don't need to, but it's best practice too, because the last thing we want to happen to Kyle is that he leaves the pharmacy, he comes back for I don't know, another set of vitamins, or he comes back for his flu shot. And perhaps it's not you, or maybe it's you because you see so many patients over a course of period of time. And you don't want to have the same conversation with Kyle, because then he'll feel like it's something that you're trying to sell him. And it's not. You really just want to start that conversation, ideally document on his patient chart if he has one, and then, or create a patient chart for him. Even though he doesn't have any prescriptions, he does have a flu shot, so he should be in your file. But if he's not, creating one for him and noting that this individual has had this discussion started. Maybe you want to note you've mentioned complications to him, you've identified that he's had chickenpox before, or maybe he's unsure. Any information you've gathered from him, just putting it down so that whether it's yourself or the other pharmacist or whomever has that discussion with him next, they are able to reflect back and say, okay, we've had this conversation. Next time when he comes in for his next OTC flu shot or whatever it might be, I just do a follow-up. So Kyle, I know we talked to you about shingles vaccine the last time you were in. Have you given it any thought? Maybe things have changed. A lot of the time in pharmacy, we feel like when a patient says no, it's a definitive answer, and that's not necessarily true. People change, circumstances change. Perhaps you read some of the literature you gave him, or perhaps something you said resonated with him and he asked a friend and he recognized he might benefit. It's, you've cracked that door open a little, and now it's just being a little persistent to see that maybe next time he's open to hearing a bit more, and then perhaps he does consider having the shingles vaccine, or he just wants a bit more information. And the fact that you'd be open to answer his questions helps him understand that you're looking out for his best interests. And oftentimes having these discussions with patients, perhaps in Kyle's case, he didn't have any medication, but if he did and he only came into your store for the flu shot, it may actually reflect onto the patient that, hey, this person really cares about me and looks at me holistically. And it may be an opportunity for them to transfer over to your store as well. So it's looking at Kyle as not necessarily, oh, he said no, he's a lost cause. It's not that. A no is not a definitive no. Persistence is always important. And the fact that we've opened that door and at least opened their minds to the concept of shingles vaccine can lead to different results. So it's important we keep that in mind. And of course, for documentation, it is optional, but it is best practice to do so. So I strongly recommend, even if it's just a few minutes out of your day, or if it's scratch on a paper and you scan it into his file, that you've documented it in there for Kyle so that he knows that you're not just trying to reiterate the same point, you're actually following up and recognizing his growth as a patient.
Okay, now we're on to something maybe a little bit more difficult. So here's Claudia, and she's 67 years old, and she is asking you about the shingles vaccine. So she's coming to say, what can you tell me about the shingles vaccine? She said that she hasn't talked about this with her doctor, who's Dr. Parker, and he's her primary care physician. But she also hasn't mentioned this to her dermatologist, Dr. Gupta. So she's not really sure if she's had chickenpox or not. It was a long time ago, can't remember. She is on an OTC vitamins and some emollients to help her with her dry patches. She's taking Humira for plaque psoriasis. And she's the kicker is she's retired and she's on a fixed income. So what would be the best way forward for her?
Mm-hmm. So she's definitely a type of patient I've seen in a lot of practices that I've worked at. Different patients have different needs, and I know you've mentioned a couple different things. She's certainly a candidate because she is immunosuppressed, because she is on a biologic for her plaque psoriasis, Humira. She's not sure if she's had chickenpox or not, but that doesn't really matter. It's good that we note it, but it's the fact that she's still susceptible to having shingles. She is 67 years old, so definitely she is within the labeled use. She's over 50, and the NACI guidelines recommend her clinical factors that she would be a candidate for the shingles vaccine. And what's interesting is the fact that you also mentioned that she's on a fixed income. And so because when a lot of our patients, especially ODB patients, are on fixed incomes, there is a hesitancy to spend anything out of pocket just because it can have such a huge impact on them. And in this case, it may be the best direction due to her conditions, as well as the fact that she's looking for it to be covered by the ODB, that you get a prescription from her doctor. So oftentimes in pharmacy and practice, we'll have like set templates. It's not very difficult, just something that has a doctor's name that specifically outlines that these are the factors, the contributing factors of why she's an ideal candidate, that you've talked and counseled with her, that you recommend that she gets the shingles vaccine. And at the bottom of the documentation, just having a quick blurb of what the prescription should be, a very easy yes or no for the doctor so that they'll be able to sign. And this isn't required, but I usually add it in as well. It's just if they do say no, the rationale as to why they say no, just because sometimes they may have insight to a patient's allergies or something that we don't have documented or weren't privy to. That's something we can now add onto the patient file, and it really shows that we've done our due diligence. And the one thing to note about this patient is that she has two physicians that she routinely sees. Most likely she sees Dr. Parker a little bit more often than she sees Dr. Gupta, but they're both her care providers. And so that we want to make sure we send this to both physicians. It's most likely Dr. Parker that we'd be looking to have the prescription from, but regardless of what Dr. Parker's answer is, we want to make sure that we fax an FYI copy to Dr. Gupta as well, so that he's aware and in his charts, he knows that this is a consideration that we've taken into account, and whether it's yes or no, we've either actioned on it or not. So the patient doesn't have the repetitive experience of this. For someone, as you mentioned, like Claudia, who's come in and actually asked that they want the shingles vaccine, kind of at an advantage because you don't have to relate all the information out to them in the sense of why it benefits them. They most likely have an idea as to why that would benefit them, but it's still important to give them an idea of what the shingles vaccine is, have that conversation very open, having that initial approach with, it's great that you want to have the shingles vaccine, but what have you heard about it? What made you decide that you wanted it? Understand what their reasoning is as to why they want the vaccine. Some people feel that having the vaccine protects them against other components, maybe because she doesn't have chickenpox before, she thinks she won't get chickenpox at all, or she thinks that it'll give her additional protection for other viruses. Just making sure that they don't have any misinformation or misconceptions as to what the vaccine does is really important, as well as letting her know that these are her options when it comes to having the vaccine. Of course, she can get it right now when it comes to the fact that she can get it in the pharmacy, but letting them recognize that there is a cost associated to that. And for someone like Claudia's situation where they're on a fixed income, it could be a little bit difficult. So giving them the options that this might take a little bit longer, but if you're open, let's fax your doctor, we'll have that conversation. And then that way there'll be coverage for you, as well as the fact that we know that your circle of care, since you do have a number of conditions, are fully aware of what's happening. And it's making sure that that dialogue's there and trying to set up with them a follow-up date as well. Because the last thing you want is for the patient to walk away from you, forget that they ever wanted the vaccine. You get the prescription from the doctor and it be a bunch of miscommunication.
I think in this case, though, in the 67-year-old, she's eligible under the publicly funded program.
Yes.
So
yes.
I think, just even referring to the doctor, so he's got it in a file to next time she comes in and
to talk to her about it. Yes,
absolutely. Yeah.
It's really just that awareness that we provide to her entire circle of care, because oftentimes we depend on the patient to convey that information, which they may forget, because usually most of what we tell them at the counter, 20% of it's retained and most of it's not necessarily. So having some form of documentation definitely helps.
Yep.
And just a few other myths to demystify for some of your patients. Some things that I've heard is I'm too old for the shingles vaccine, so there's really no such thing. There are caps on to what provincial coverage will provide. For example, ODB is 65 to 70, but that does not mean a patient over 70 cannot get the vaccine. And the other that I've heard is I'm too young for shingles vaccine. So as long as they're above the age of 50, they are a candidate for the vaccine and they are an on-label user. I've also heard, I don't know if I have had chickenpox or not, so it's best I don't get the vaccine, which is actually the contrary. It's important that you do get the vaccine because not having chickenpox means that you could potentially contract chickenpox from someone who may have the shingles, as well as the fact that their blisters have not crusted over. And if you do have direct or indirect contact with them, you could get adult chickenpox, and then potentially the reactivation could lead to shingles occurring for you. And the last one is something I actually recently heard in practice was my spouse just got shingles. It's too late for me to get vaccinated. I'm already exposed. And this kind of goes back to the fact that a lot of people think that shingles is like a common cold or the flu or another virus that you catch. And again, explaining to them that that's not how shingles works, and they can still get vaccinated for shingles. And it's important that they do because they have a loved one they see going through that pain and suffering. So they know it's something they definitely don't want to go through as well. And here, just to sum it up, I have a couple of the NACI guidelines that we've reflected in a lot of our recommendations. Against anything that we document, that we send as a fax, that we send as any sort of on any platform digital or any record that we send, we really want to make sure we reference as much as possible. So referencing the NACI guidelines or any other journals that you use is important to show where you've come up with the recommendations and what it was based on. And with that, I wanted to get into the component of how to set up a program on shingles in your pharmacy. I know we've talked a lot about what is shingles, how do you get it, a lot of the clinical information, gone through a few cases and how to approach different types of patients that may come into your pharmacy. But if you don't have a program already or aren't familiar how to set up a program, how would you do this in your pharmacy? So one of the initial things to look at is your pharmacy aware of what demographics they have? And are your pharmacy staff aware of who you're really looking at? You want your staff, as well as any pharmacists, to understand that shingles vaccines are indicated for individuals who are over the 50 or over. However, if someone is over the age of 65, there are some workflow differentiations that you need to make if they are choosing to have it publicly covered. And we'll go through over other public coverage as well. And as well, recognizing what constitutes a patient being at high risk, knowing that one is definitely age, but also recognizing medication that they're on may put them at higher risk, as well as having that conversation with those patients may lead to you understanding social or lifestyle factors that you can document as a rationale as to why you've recommended and or administered shingles vaccine for that patient. So looking at your store, depending on the type of store you are, you may be corporate, you may be independent, you may be franchised. There's a couple of different approaches you can take. If you are choosing to take this opportunity on the fact that the shingles vaccine no longer requires a prescription, marketing in store is definitely important, making sure that the individuals that walk into your store recognize this is something that's available to them. But if you happen to be co-located with a family practice or another healthcare provider, reaching out to them and seeing if it's something that they'd be willing to market for you as well. So definitely having signage of some sort helps the awareness of the fact that you're able to provide this to your patients. One thing that we've done is also attaching it as a recommendation at the end of a medication review. We are reviewing patients, we're asking these questions that we need to ask regardless, making sure that for those that fall within a certain age category, that when we're doing a medication review, we ask, have you considered the shingles vaccine? Have you had chickenpox before? To make sure that now that's something that's in their minds. It may be that some say yes right at that point, and it could be something they're open to pay, or they may have private coverage for, that you're able to allow and administer at that point. Or it could be something that you utilize a platform or you set up a different time for them to come in to be able to talk to you or have that administration. It's also something that's really timely right now because flu season's coming out. It's an opportunity to kind of piggyback it with other vaccines to recognize that people are aware, especially with COVID-19, the heightened importance of vaccines. You've kind of got both sides of the coin. You've got some patients that really understand the importance of vaccines and are advocates for it, some that are hesitant. But this is a time to help basically both patients, ones that are advocates are easier, understand that all vaccines are important. It's not just against COVID-19. It's not just your flu shot. Shingles is just as important, and have that conversation with them. And for those who are hesitant, as you have those discussions with them to help them understand the importance, it's again kind of shows the fact that all vaccines are helpful. We see its support in COVID-19, we see its support when it comes to flu season, and we see the impact that a shingles vaccine can have in helping prevent the pain that someone could experience if they got shingles. You can have targeted awareness campaigns. So this could be those who are within a certain range. You take a look at the medication that they're on, so you know that they have dual triggers, both age as well as immunosuppressant medication, and reach out to those and make sure those patients are aware that they may want to consider the shingles vaccine. And as well, you may want to tag it on as an FYI for prescription refills that you see patients come in. And finally, if you happen to be a type of pharmacy that's within the vicinity of other local businesses and you have relationships with other local businesses, it is something that you can promote to different HRs. So different human resource systems, especially for those who may have vaccine coverage in their benefits plans or who are very aware and advocates of vaccines, may want to promote the fact that you want to reach out to your pharmacist and talk about your shingles vaccine. So, and it's something to have that dialogue with, and it really helps the awareness of patients. And a lot of us feel that patients who may not have coverage, something out of pocket, they don't want to consider. That's not necessarily the fact. And just having the awareness that this is out there, you'd be surprised of how many patients are open to hearing about it. And finally, I kind of wanted to touch back on making some connections. I know Ruth had already mentioned the tool that OPA had designed to kind of flow the discussions that you have with your patients to see how the conversation may be started as well as followed through for different types of patients. It's very helpful and goes into a lot of detail, and I believe she provided it in the chat, but regardless, it'll be provided to you. I just wanted to go through some high-level concepts on that, is that really some of the components from workflow is you want to ensure that all your pharmacy staff are aware as well as open to the offering. You want to set up a workflow as well as paper documentation system as much as possible, along with making sure you have the right SOPs. If you're a busy pharmacy, you may want to consider an appointment-based system. So similar to signing up for your COVID shots or your flu shots, you may want to have something for shingles vaccines, as well as it's really important for adherence. Having that patient walk through the door for the first dose isn't enough. We want to make sure that they come in for the second dose to complete their entire series. And for that, it's any platform that you have. If you have a reminder platform, utilizing that. If you don't have that, I know GSK has one on their website that if you have that patient sitting down for their first dose, have that conversation at the end of their dose. They're going to have to sit around and wait with you anyway. What would be an ideal date for the second dose? And just sign them up for that reminder platform right then and there. So both you and them have a reminder to make sure they complete their entire series of doses. Finally, I think I'm running out of time, but COVID-19 has really highlighted our role when it comes to healthcare providers. We are the most accessible and the most easily communicatable individuals for a lot of patients who aren't able to see their prescribers. COVID-19 has highlighted that. And because of that, there's truly an importance placed on the fact that we're able to support with the shingles vaccine. Previously, it was stated that you'd have to wait 14 days before and 28 days after if they've had their COVID vaccine. This is no longer the case, as Ruth had mentioned at the beginning of this presentation. It is now open for them to have the shingles vaccine within a shorter time frame. And I just wanted to touch on the fact that if all of you feel comfortable or able to have this service promoted or marketed in your pharmacy, probably most of you do, but for those who don't, there's a lot of services as well as tools that are available online, mostly free of charge, that can really help you design your pharmacy to meet your patients' holistic needs. And I have 2 minutes, but I really want to touch on different coverage options because it's so important. One of the ones that we really see here in Ontario is obviously the ODB public coverage component. This is where most patients fall. And of course, for, as Ruth had mentioned, anyone who's over 65 years of age, you want to make sure their prescriber is aware and you go through that route and make sure that they have coverage. But there's also NIHB for patients where they're able to get coverage from pharmacists as well. So those patients, again, fall between that 65 to 70 year age. And there's Veterans Affairs for Canada. And for those individuals, it's anyone who's 50 years or over that would have public coverage in that realm. There is private coverage as well. Private coverage is a little bit different depending on the carrier or the plan that the individual uses and their specific employer group benefit design. They may have vaccine coverage. In that case, oftentimes you'll see it covered at point of sale. So when you adjudicate, you will see that the vaccine is covered. However, if they don't have that coverage, doesn't mean that they don't. A lot of people have healthcare spending accounts. This is kind of a tricky component where you want to make sure when you have that conversation, it's a pay and submit component for the patient. Some plans will cover it, some plans will not. Some will require physician script prescription, some will not. Some patients don't mind. They'll say, I'll pay. If they cover, they cover. If they don't, they don't. Feel free to approach, but just make that very clear to the patient so they don't feel like they're going to get coverage in case they get a rejection. And finally, it can be a cash or out-of-pocket expense. But for those who understand the pain that's associated with shingles, it's something a lot of people are willing to do just because of the benefits that it provides and the security and protection it provides them. So really understanding that you're not selling something that they don't need, you're really giving them the opportunity to take something that will truly benefit them, and helping them understand that is really our role in all of this. I definitely don't have time to go over administration of Shingrix, but GSK has an amazing tool that goes over exactly how to reconstitute as well as administer the IM injection. So I know that'll be provided. And the last question I did have is, after this presentation, how many of you feel comfortable offering shingles vaccines to your patients? And if it's something you feel you would do now? And I think we can't open the poll again.
So no, we can't open the poll, but you will be asked that question in a survey at the end. So
perfect. And hopefully it has helped. And I know some of the components have gone over quite quickly. But again, if any of you have any outstanding questions, feel free to message them in. I'm happy to respond and give you as much information as possible. But really, I'm hoping some takeaways that you took from this is know who's eligible for the vaccine, understand how to approach patients on recommending the vaccine to remove that hesitancy, know how to handle different patients. Some are those of paths of least resistance. Some of those will really have a lot of misinformation and myths to debunk, as well as recognizing how to download the tool from the OPA pharmacy, as well as that will be sent to you, I believe, by Ruth in some form or manner. And just saying that shingles can be painful, but prevention can be priceless. And that's something we really want to emphasize to our patients. Okay.
Okay. We have questions, Pav. Thank you so much.
No problem.
So this one was early on. So the patient has not had chicken pox, but has antibodies. Mm-hmm. Should the patient take the shingles shot?
Yes. So even if the patient has technically not had chickenpox, but they have antibodies, it is recommended that everyone get the shingles vaccine because of two reasons. They may, by chance, come into contact with someone and potentially may not have chickenpox, but exposed to the virus, that could technically get reactivated for them. So it's still recommended that they get the shot.
Okay. So I don't know if you have any thoughts on this. What are your thoughts on patients who claim that the COVID vaccine causes shingles?
I haven't seen any literature to support this. I personally don't know if I can justify the claim to be true. Regardless, I think if they do believe that's true, I think that's an additional factor of why they'd want to protect themselves against shingles. So they'd want to get the vaccine if possible.
Yeah, I think maybe there's, it's been a stressful time for a lot of people. So perhaps even just getting the COVID shot and the stress
yes,
of the shot, it's quite a relief for many people. It's if you're not
impacts the immune system. Yeah.
Who knows? So let's see. Will pharmacists receive an ejection fee if it's administered without a prescription?
You can charge an injection fee to the patient if you choose so, because it is a service that you are providing. However, it depends on the type of pharmacy you are, if you're an independent pharmacy or if you're part of a corporate chain or a corporate pharmacy, what that fee is. So it really depends on that. But it's similar to any kind of out-of-pocket or cash service that you provide. It's up to you to set that fee.
Do you know if private plans or something like NIHB would, if you are the prescriber of the Shingrix vaccine, would they accept the pharmacist as the prescriber and cover the shot?
So it's hard to say that they all would. I'm going to say no for all, but there are some that will. So depending on the patient's plan, if their plan recognizes pharmacists, and surprisingly many do as a prescriber, they will allow the member, if they have vaccine coverage, to have a prescription from the pharmacist, it to be dispensed and covered. So it depends on how the plan is set up, but it doesn't hurt. There are plans that do accept that.
Okay. And so a lot of people ask that question because it's hard to know. Every plan's different.
Yes, every plan's different, but you can always ask the patient. They usually have either on their app or a number that they can call to find that out. And if they're open to it, as long as the patient's there, you can call their carrier with their specific group number and plan information and get that information.
Okay, so what if we've had this situation? What if they have no private coverage? They just want to get the shot. What can they pay with, or do we still need a doctor's prescription?
No, if they are open to paying out of pocket, absolutely. We've removed the sludge of requiring a doctor's prescription. You're able to have that conversation with them. Again, it is Schedule II, but you need to make sure the pharmacist or yourself is there to have that conversation, recognize, document, counsel, can get consent that the patient wants it. But if they have provided all that, absolutely, you can dispense and charge whatever fee your regular injection administration would be.
Okay. Can people get Shingrix if they've had Zostavax before?
Yes, so they can get Shingrix if they've had Zostavax before. It doesn't matter, regardless of the fact that they've had Zostavax, you would want them to get the full series of Shingrix, both 1 and 2 injections.
Okay. This question we sort of answered at the beginning. Can people get the vaccine independent of when they have had or will have their COVID vaccines?
Oh, yes.
I think Nancy answered that one for us. So,
thank you, Nancy.
well, yesterday it wasn't true, and now it is.
Now it is.
Just life and in the world we live in today. So, is it true that if you have the chickenpox vaccine, you will not get shingles?
If you have the chickenpox vaccine, as in
as a child, like a lot of children get it now as a natural thing.
Yes. So technically you can still get shingles in the sense that chickenpox vaccine, you may still get exposed to someone who may have chickenpox or may have shingles specifically. That direct or indirect contact still means that virus can technically go into your system and then lay latent. And if there is some sort of fluctuation from an immune system's perspective, or as you age, you do have the potential of getting shingles in that case.
Okay. And what if somebody had shingles in their 30s? Should they wait until they're 50 to get Shingrix, or should they get it any sooner?
So if someone has had shingles in their 30s, it is off-label. It is something that you will need to have a discussion with the prescriber for. It's not something that's a Schedule II product that you can walk into a pharmacy and purchase and pay out of pocket. But I would recommend they have that discussion with their physician. So if their physician recognizing that they've had shingles before, and we do see that 6.41% have reoccurrence of it, so there is a chance they could get it again, and they probably know how horrific it is. That's something that I would, depending on the patient, I would probably fax the physician saying that they've come in, they've asked for this, here's some information about it, how do you feel? I wouldn't necessarily specify that I recommend, because I don't know if how the physician will feel about the off-label, but I'll give them all the information. And please consider the patient has had shingles before at age 30. Would you consider prescribing Shingrix or a shingles vaccine for this patient? And wait to hear back from the physician on that, because it's definitely an off-label use and we need the prescriber to decide on that.
Okay. And here's an important point. So now it's Schedule II. You just don't take a box off the shelf and hand it over. You need to think about record keeping and documentation. And we touched on documentation a little bit, but could you just sort of explore what that would be in a pharmacy? Now, given that, obviously there's corporate rules, et cetera, but not everybody has that. What would you recommend that people do?
Absolutely. Because it's Schedule II, but like you said, it's not something that's cold medicine that we can just have that conversation alone. We really need to document on what we said to the patient. I would recommend one of two things, depending on the system that you have, and again, depending on the corporate structure that you have. If you don't have anything in place, some of the easiest things that you can do is, again, taking a prescription pad and just writing down the notes in your recommendation and scanning that into the system. You want to make sure it's attached to the patient file, and if if the patient does say yes, or you end up administering an injection for them, it's attached to that prescription RX number as well, just to make sure that it's co-referenced to each other. You want to make sure it's there, it's readily accessible, it's clear, it's legible. So if anyone at any point comes to you and asks, okay, patient ABC, whatever their name might be, got an injection for you, why did you do this? You can easily pull it up, regardless of if it was you or another staff member, and know exactly why it was recommended. And the same thing for the consent. You want some sort of consent documented, whether your system allows you to type it in or you have to write it and scan it. You just want to make sure that that's there for them.
Yeah, I think that's important, and putting it through the as if it's a prescription is important. I think for record keeping, a lot of people have these virtual inventories that they need to keep track of, and yeah, you definitely Schedule 2 offers is a little bit more tightness, and if they're a regular patient of yours, it's important that you have even Schedule 2 items documented in their patient profile. Because when you do a medication review, you're not going to repeat, if you see Shingrix done, you're not going to repeat that question during a medication review. So
absolutely, it helps your patients feel like they're really being followed rather than just someone you're offering something over and over again to.
Exactly. And then this one is a good one as well. Talking about the second dose. So COVID's shifted a lot of people in not getting doses. Could you maybe comment on what if it has been over 6 months since they had their first shot?
Yes, absolutely. So technically, the second shot should be had between 2 to 6 months, but obviously COVID's kind of deterred a lot of that. We do recognize that if it's been past that 6-month mark, it's okay to still give the second dose. They don't need to start the series over again. Studies have actually shown that up to 12 months, there's been information on that. So it's not about starting the series again. You can just administer the second dose if it's past 6 months.
Okay. Here's a tough question.
Oh, goody.
Well, it's maybe just an opinion. So what if somebody comes to your pharmacy with a bag and from another pharmacy that they bought the Shingrix from another pharmacy and they want you to administer it for them?
So that is a very good question. There's a lot of considerations there. So again, a lot of this kind of falls in the realm of your professional judgment, but best practice and my recommendation for something like this is you're seeing a medication or a product that's coming to your pharmacy externally. You don't know if anything's happened to it along the way. You don't know if it's been tampered with. You have no idea about what the current chain for that, or not cold chain, but general chain for that specific product is. So you're taking your risk and liability by administering that. So my best practice recommendation to any patient would be that you don't take medication that's been brought in by the patient. You recommend that they have that conversation and they also get the administration from that same pharmacy, ideally yours.
Yeah. Okay. Yeah, that's a tough one.
Yeah.
What was the other one? Do they have to receive the vaccine on site?
If you're administering it in the pharmacy, yes, it has to be. Like, you can't go to the patient's home and administer it, or another location. However, if they're purchasing it from you and they're getting it administered at the doctor's office, that's a different component. Yeah.
And finally, here's another one. What if they're a patient? They're not your regular patient. It's just this kind of come off the street. Maybe you have a sign that says Shingrix.
All the marketing. Yes. So if all the marketing has lured in patients,
not a regular, they might have a lot of other conditions, but you don't know.
So if it's a patient that's coming externally and you have no information about them, I really recommend best practice is you spend time with them, and quite a bit of time. You want to set them up with the patient profile in your practice, even if it's a Schedule 2 and they're paying out of pocket and they don't need a prescription, it doesn't matter. You want to make sure they don't have any allergies. You want to make sure that any of their medications or conditions won't be impacted or contraindicated for shingles vaccine, and you want to make sure that you have that documented somewhere. And one additional step you can take, but it's not necessary, again, it's best practice, is that you find out who their primary care provider is, their family physician. You really, ideally, the circle of care, you want them to know that you've administered this or they've purchased this, to make sure that you have that full patient profile.
Yeah, that sounds like a good answer. I'm always thinking of the college.
Oh, yes, document
Sorry.
everything.
But it's just good practice. It's good practice. I want to thank you, Pav, for a very interesting presentation. I'm hoping that, COVID's changed a lot. We do still have this public health role in helping people stay safe, whether it's their respiratory health or their, preventing shingles. And they don't always see their doctors anymore, and doctors are still virtual. So the conversations are probably not as broad as they were before. So I think that there is an opportunity here, and to continue to demonstrate the role of the pharmacist and holistic patient care is the way I look at it. So I want to thank you, and I want to thank everyone for participating tonight. You'll be getting an email in a couple of days, and it'll have the recording and the PowerPoint and also the tool. So really happy that you all came tonight, and really happy that Pav was here. Take care, everybody, and have a great
Thanks,
night.
everyone. It was a pleasure.
Bye.
Thanks, everyone. Bye.